Hello, my name is Diane and I'm working with Arzu on our final project for CSCI1090B, and we did a project related to the prediction of Medicare prescription costs in the United States. Now let's get to the problem. So the reason that we were interested in this problem is because of the high cost of healthcare worldwide, but particularly in the US. We decided to tackle this particular question through the lens of Medicare, and specifically Medicare Part D, which is prescription costs. The data we have is actually synthetic data, so it was created to be able to look at general Medicare costs without providing personal health information. We have 7,400 beneficiaries and just over 500,000 prescriptions for those beneficiaries. For the beneficiaries, we've got demographic data, including age, race, ethnicity, gender, and then also some information about the geography for their residence in the US. And we have the reason that they qualified for Medicare, whether it was age or a clinical condition. We also know about the pharmacies, the prescriptions, whether they were brand or generic, and which pharmacy type they used. For exploratory data analysis, one of the first things that we did was some descriptive statistics to learn a little bit more about our data and distributions. What we found is that there are some aspects of the data that are most likely fairly representative of true Medicare data. So for example, looking at the race and ethnicity data, we can see that the breakdown is fairly representative of the US population as a whole. On the other hand, we saw that for some of the other variables, such as pharmacy type, the percentages were almost exactly the same across different pharmacy types. So our suspicion is that those were actually sampled from a uniform distribution. We can see from the histogram of number of prescriptions that the data are quite skewed. So there are a smaller number of individuals who have a high number of prescriptions, and the vast majority of individuals have much smaller number of prescriptions. So we actually ended up presenting these on a log scale. We see the same phenomenon with the total prescription costs as well as the cost to the beneficiaries themselves. So these data are also presented on a log scale. One other thing that we did was dimensionality reduction with t-SNE plots to get a sense of how many different clusters of data we should be looking at. And what we identified from this exploratory analysis is that there were a small number of high-cost patients that represented the majority of the spending that we were interested in.
Hello, I'm Arzu. We began modeling with a simple linear regression. We selected predictors using domain knowledge and exploratory analysis. After long transforming the outcome, we split the data into training and test sets and evaluated performance using mean absolute error and R-squared. To improve on the linear model, we built 4 more advanced models. Each of these can capture different kinds of relationship in data. For example, random forest can handle interactions and nonlinearities without prior specification. Neural network can work well with high-dimensional data, and XGBoost is known for strong tabular performance. We trained all models using the same 80-20 train test splits for fair comparison. We used scaling where needed and consistent categorical encoding. And one of the biggest challenges we faced was modeling the very high cost beneficiaries. Even with log transformation, those cases are still hard to predict. A key reason for this is the lack of clinical or comorbidity data in our dataset, important drivers of healthcare spending that we couldn't capture. Still, this pre-processing step helped us improve model performance substantially compared to the baseline. The linear gave us a useful benchmark but struggled with capturing the nonlinear patterns in the data. When we compare model performance, random forest stood out as the best overall performer. It had the lowest mean absolute error and gave relatively consistent predictions across different cost ranges. Linear regression performed worse, particularly for individuals with high costs. The neural network and XG-based models came close to random forests but didn't surpass in terms of accuracy. Interestingly, Bayesian regression didn't offer much improvement. It seems that modeling uncertainty alone isn't sufficient for strong results. Finally, what did we learn? Prescription costs are highly concentrated. A small number of people account for most spending. While machine learning models like random forests can significantly outperform linear models, none of them perfectly capture the most expensive patients. This is likely due to missing clinical features like diagnosis or comorbidities that influence treatment costs. Still, our models can show that meaningful cost prediction is possible using just demographic and prescriptions level features. To improve this project, we can add richer real data, try transformer models, use smarter tuning methods. Thank you.